Thank you, Prof. I'll get you back later. You'll see in my presentation. I'm actually quite nervous this morning because this project really means a lot to me. I believe that it holds a lot of potential answers for the future. And so the presentation I'm going to give is really a bit about how it came about, the conceptualization, and the theory or some of the ideas behind it. That does not mean that we've achieved that yet. It means it's an ongoing work in progress, but this is the end vision that I'm presenting. Okay? So, first of all, COSUP stands for Community-Oriented Substance Use Program. And really, it's a way of using the community-oriented primary care approach to addressing drug use. And so we have a drug and alcohol continuum of use. Okay? It starts with experimentation, recreation, and using DSM criteria, which are not perhaps my favorite criteria to use, but just for the sake of ease and so we understand what we're talking about, I use the mild, moderate, and severe. And people move up and down this continuum. All right? But the thing is, no matter where you are on the continuum, and no matter what drugs you're using, in South Africa we only have 2 responses. Well, one response divided in 2. We see you as a zombie, and if you're fortunate enough, you get medical treatment, and if you're less fortunate, you go into the criminal justice system. And if you're living in a community of people, as this young man is, and there are people around you using drugs, and you happen to get caught, even if they're using drugs which are potentially more harmful, what happens is you get removed from that part of the community. You either go to jail or you become pathologized. The one thing about a jail sentence is it's got a term, and at the end of it, you finish serving it, but if you're overly pathologized, it's a lifelong sentence. And so, like many of you have seen that video with Rat Park, you become a bit like that rat in Rat Park. So often our response to drug use drives further drug use because you have been separated from the community, you have been othered, you have been labeled. Now here I've got a statement. I used a statement from the UK for one very simple reason. Because I didn't want to offend anybody in the room who happens to belong to one of the political parties here. You never know who's going to come into power in the future, and so I didn't want to destroy any chances of continued funding. But you will recognize the words here as words which we hear all the time, this rhetoric about drugs, right? But nobody ever talks about that picture that's there, the conditions that people live in. We tend to focus on the individual rather than the community, rather than the setting, and rather than the policy landscape that often drives the use of drugs. And up here, I've got a couple of statements from people, and these were the statements that I was getting from people as I was doing some research a few years ago. Some of the people actually from these statements are in this room. And they tell a very different story to the popular story about the criminal or the madman. You know, you're mad, bad, or sad. But these tell me a very different story. They tell me about people who are real survivors, people who are making their way in the world. And this got me to do some research on what should this thing called treatment look like. It should be relevant. A lot of this is based on the work of Miller, by the way, and some analyses done by Mike Ashton. Should be relevant. Also Andrew Tatarsky, for those of you who know him. It should be welcoming. Low threshold. That means that it should be easy to access. You shouldn't have these requirements of abstinence. It should be available immediately. It must be accessible. It can be brief and in a non-specific setting, as in brief interventions, which sometimes are just as effective as long-term interventions. It needs to be individualized. Everyone is different. It should allow for the resolution of past issues if there's trauma. It should look beyond the drugs and drug use, and it needs to be collaborative. That collaborative one is very interesting for me because there are a lot of people who don't believe that you can collaborate with somebody who's using drugs. But I want to see who you would prefer to work with? A heroin-dependent individual who is in heavy withdrawal, or a heroin-dependent individual who has just had a good dose of diamorphine, preferably. And I was contemplating these questions, and I met Prof. Hugo. And that meeting was catalyzed by this statement, legalize NIOPE, that was spread everywhere. Now, we were at a press conference together. I think it was the second or third time we'd met. Am I correct? We were at a press conference together, and the prof was misquoted. Not widely misquoted, but he was misquoted. It was a slight misinterpretation. And for those of you who don't know what NIOPE is, no, it's not ARVs, it's not rat poison. And you can go and speak to the other prof here. It is opioids, usually a low-grade heroin, often sprinkled on top of cannabis and smoked with cannabis, but also it's the white heroin as well that people inject. And we were on a TV interview together. Unfortunately, I was over Skype, and all you heard was, NIOPE is cannabis. So that didn't do anything to save the problem, because obviously I'd said a lot more in the middle, but you know, it didn't solve the problem of people not knowing quite what NIOPE is. In fact, at one stage, they decided that they needed to criminalize the use of NIOPE, although it is basically heroin. So I started speaking to Prof. Hugo and Prof. Marcus, and I met Dr. Krokamp, and I heard about this thing called the community-oriented primary care system, and it's something that was developed in South Africa and is used around the world. I'm not going to go into this right now because we don't have time, but basically it's a very cost-effective way of delivering health and well-being to people, and you'll see why that is in a moment. And here we've got a comparison between Cuba and the United States, and it shows you that basically for a tiny spend, Cuba has as good a health system, if not better, than the United States. If you want to debate that, speak to Prof. Hugo. He's been there and he's had a look at it. And there's certain principles that are applied in this model. It's a local institutional support assessment, where you go into an area, you work with the community, and you determine what resources are already there, which resources can be repurposed, which resources you can train, who you can work with, who you can get buy-in from, right? It's about comprehensive care, it's about equity, it's about practice with science, the melding of the two together. It's about service integration around users about the service users, all right? It's a sort of holistic approach, to use a very trite term, or overused term, should I say. And it's based on ward-based outreach teams, and it uses a principle called high-touch, high-tech, which we'll look at the moment. But basically, you've got these teams which have got community health workers, and each community health worker sees 250 houses a year. And what you get out of this is you get referral pathways, triage, individual assessment, and household registrations taking place. I'm not going to go into that now, but basically what Prof. Hugo said to me, it's basically geographically organized healthcare. So nobody has to move long distances to be able to get the healthcare that they need, and we're doing a lot of preventative work in that kind of model, and it's very data-rich. It produces a lot of data because it's got this high-touch system where you've got a relationship with the people, the community health workers, and this is in an ideal world, of course, are part of the community. They regularly see people. There's high retention because they can't really go anywhere. They're part of the system. And there's this referral process. And the high tech is everything's done on a handheld device. Okay, so this is a sort of a primary healthcare model. And I went back to my original thing of what should treatment look like. And I had this brilliant idea. Okay, well, I thought it was brilliant anyway. And I went back to my drug and alcohol continuum and I said, hang on a second, this continuum doesn't start with experimentation. It starts with maybe maternal use or maternal non-use. It then moves into the family setting. And the young child, what's going to make that child interested in using drugs at an early age? And so, building on some of the World Health Organization models, we need to have this health promotion, prevention, intervention, this complete continuum of care. Because then we have a very low probability of reaching the end of that continuum, right? And all we want to do is build more rehabs. Now what we've got is we've got a community, and we've got healthcare moving into the community, not the community trying to find healthcare. And that's a bit like having a distribution network or a drip into the system. So what should happen, ideally, is we shouldn't have all these parallel systems. We should bring those systems in and put them on top according to what the epidemic is in that particular area. Okay, and I'm not likening drug use directly to an epidemic. So through the LISA process, through the use of the substance use module, because all you do is you plug that into the system, the handheld system, and now you know, which we've never known before, and we hopefully will know in the future, the prevalence data, the types of drugs, the method of use, the resources available, and the community support. And I remember that when Prof. Hugo and the team, they did an initial small sample, and they found 8 people in the suburbs injecting heroin. And we were being told that there are no injecting heroin users, or very few, anyway. So now we understand the extent of the problem, or potentially understand the extent of the problem. And what we can then do is we can start laying a harm reduction approach. We can use the LISA analysis to speak to people about putting down a harm reduction approach which has no judgment, everybody's treated equally, come as you are, using peers, particularly incremental steps, and providing a scaffolding of support for people. And on top of this, you can put your drug support sites with psychosocial services if that's what people want. Your clinical services are already there because you're part of the public health and well-being system, and your specialist harm reduction services for people who inject drugs. By the way, I put that separately because people tend to think that that's where harm reduction starts and ends, and it doesn't. Harm reduction is a much broader philosophy, of which that is one manifestation of that philosophy for a particular population. And then, of course, this is housed within a casing of education and research, passing on the knowledge and finding out what actually works. And what happens is, overall, we get this very integrated system, which actually I don't like calling a public health system. I like calling it a public well-being system, because you've got a continuum of your team, which start with people who are peers, who are community health workers, who are in effect peers as well, going right up to the specialists you need in a particular area. All right? And so if we come back to this model, we can now start implementing realistically interventions along the continuum of care, starting right with food security for pregnant mothers, because you know what the food security is of the particular households. Now, this all sounds very good and very nice, and it is difficult to implement if you don't have the basic system. And I'm sure you'll hear from others that there are compromises that have to be made and have been made in the system because of a failed health system that's existing. But if the health system is working well, this can be overlaid, or alternatively, the health system can start plugging into this. And what that gives you is in a tremendous economies of scale, because you're not setting up new programs each time. You're using community members, and your community members feed into your clinical teams, your multidisciplinary teams. And they're informing, by the data and by the word of mouth and the narrative, what's needed in that particular community. And let me tell you, it's not more drug education. It's not more talk about drugs. It's not more drug treatment, which in large extent is a misnomer. Mark Willenbring, former head of the NIAAA in the United States, he says there is not one single robust study that says that 28-day treatment does any better than spontaneous remission rates, and actually in a lot of cases does a lot worse. We don't need to spend all that money, those millions on rehabs. We should be spending the money on the health promotion, the prevention side of things, and when the people are injecting, harm reduction, harm reduction, harm reduction. Because if you use the term recover, which I don't, dead people don't recover. And this is from a statement from somebody in the program. I think that says a lot. In fact, it pretty much says everything. But a lot of people don't like these kinds of approaches because they want to cure, they want to fix. And my good friend Mark Lewis wrote those words about a scaffolding, and that's what it is. It's a temporary scaffolding that we need to provide people, because in majority of cases, people who have problems with drug use, it's not always seated within the individual. It's often seated in the context. But the individual can make individual changes that might benefit them. And the only outcome we should be seeking is not to cure, not to change, not to enforce, but is to empower. And contrary to many people's belief, people who use drugs are quite capable of making informed, conscious decisions about their drug use when given the opportunity and the right support. I end with this slide by William Miller. And if you're not improving the quality of a person's life, if you are insisting on abstinence-based treatment and increasing the risk of mortality, I ask you, what are you doing? You're satisfying your own ego, not the needs of the people you're serving. Thank you very much.